Afternoon. I'm Governor Mark Dayton of Minnesota, and I chair the NJ's Homeland Security and Public Safety Committee. We're pleased to co-host this session with our Health and Human Services Committee, chaired by Governor Kate Brown. However, Governor Brown is unable to be with us due to a major fire disaster in Oregon. Fortunately, Louisiana Governor John Bel Edwards is stepping in to co-chair today's session. Governor Edwards, do you care to make any opening remarks?
Yes, sir. Thank you, Governor Dayton, and it's a pleasure to be here with all of you to discuss something so important. I also want to thank the National Governors Association for its work in putting this discussion together and continuing to highlight this important issue. And as governors, we have to continue to work to amplify our efforts to bend the curve and push for additional resources to end this epidemic and addressing not just opioid use disorder, but all substance use disorders. While the nation and individual states have increased focus on substance use, we all still face numerous challenges, and I can tell you that Louisiana is no different. While the opioid epidemic is happening now, it's really only a symptom of a larger problem, addiction, and to an even bigger extent, mental health issues, which drive these problems. Right now, the focus is on opioids, but addressing substance use disorders is at the core of our challenge. Addiction is a lifelong challenge for people, and we need strategies equally long-lasting. And I think as governors, it's critical that we understand how these deadly drugs are making their way onto our streets, into our communities, and our homes. And with its evolution, we must be nimble in our approach and prepared to respond to what comes next. So we have to correctly anticipate the evolutionary changes and then game plan effectively. This requires a deep partnership between those tracking and interdicting these drugs and those standing up treatment and recovery services. It also requires that federal, state, and local governments remain coordinated. Now, to face this epidemic in Louisiana, we are approaching this with a multi-pronged effort. It's a call to action, and Louisiana's framework includes prevention, like better practices for pain management and opioid prescription practices through changes in law and Medicaid policy. Over the last couple of years, Louisiana has seen legislation and policy focused on prescription day limits and prescriber reporting. And prevention should also include media campaigns for public education around opioids and consequences of substance use in general. Intervention or rescue by utilizing and promoting overdose reversing drugs through naloxone standing orders or supporting naloxone distribution to community providers and first responders has also been a big part of our efforts. We've also worked to improve access to treatment and recovery services through grant funds and expanded Medicaid services. We also work to collect and report better data around SUDs to provide more accurate, comprehensive, and timely data on the opioid epidemic. States can implement action through policy and legislative change and involve the public. Every state's plan should include policy changes that affect those who receive and prescribe opioids and implement meaningful legislation. Policy that embraces a meaningful response to substance use epidemics must address access to insurance and treatment. Now, through Medicaid expansion in Louisiana, as access to insurance has increased, states like Louisiana, I should say, who've expanded Medicaid have seen significant positive impact on our residents in terms of increased access to addiction services. Overall, since we expanded in January of 2016, we have 460,000 people who received health care coverage. And Medicaid expansion has had a significant positive impact on access to care, in addition to lowering the prescription of opioid drugs and pills in our state. According to our Board of Pharmacy, which administers the prescription drug monitoring program, even though we have 460,000 additional people on health care coverage, both the total number of prescriptions and the total number of pills prescribed have actually decreased since Medicaid expansion. We also have to focus on increasing the service Array through utilization of initiatives like CMS's 1115 demonstration waivers for substance use disorders. This allows states to be creative in how they attack addiction. In Louisiana, our 1115 waiver ensures continued access to vital SUD treatment services, and it permits LDH, our Department of Health, through our contracted Medicaid managed care organizations to continue to provide medically necessary SUD services in the most appropriate setting for the member, regardless of the length of stay, so long as it is in a manner that's most cost-effective for state and federal taxpayers. And all of these changes should start with educating the public on the problem. Inform the public by creating data collection website. For example, Louisiana captures information on fatal and non-fatal opioid overdoses, and this website will be extremely beneficial in our overall ability to affect change and improve public health knowledge surrounding the opioid epidemic. Gather public input through local town hall style meetings or online surveys that are open to the public. The community, people who have been directly affected by substance use in their families or the source of valuable information, and they have to be considered in the development of any plan if it's going to be comprehensive. And today we have the opportunity to help facilitate this important conversation and elaborate on our individual approaches, learning from each other. Joining us as we have federal leaders charged with both interdiction and treatment, and a leading expert in substance use disorder. And our panel will help put us in a better place in understanding emerging trends in the interdiction of opioids and other illicit drugs. And I know we all share the same goal. We must end this crisis by preventing new cases of addiction and expanding access to treatment and recovery services. So I look forward to our conversations today and to hearing from all of you on how states and the federal government should be ready to respond in a rapidly changing environment. Thank you very much.
Thank you, Governor Edwards. Our distinguished panelists this afternoon are somewhere. Okay, sorry. Director James Carroll, the Acting Director of the U.S. Office of National Drug Control Policy. Director Carroll is the Principal Advisor to the President on drug control issues and is charged with coordinating the development, implementation, and assessment of U.S. drug policy. In doing so, he coordinates funding across 16 different federal departments and agencies. That by itself is a pretty enormous task. Director Robert Raines is the Executive Director for International Operations at the United States Postal Service. He will discuss the critical role of the Postal Service in slowing the shipment of opioids and illicit drugs. Dr. Andrew Kolodny is co-director of opioid policy research at Brandeis University, where he is a nationally recognized expert on opioid addiction. He will provide us with insights on how states can develop their treatment resources to address substance abuse disorder now and in the future. After their presentations, National Public Radio's Scott Hensley will moderate the panel's discussions. Mr. Hensley is the editor and host of NPR's very popular program, Shots, its online health channel. I want to thank the four of you for joining us today. Again, Director Carroll. Thank you.
Good afternoon. Thank you, Governor, and thank you to NGA for allowing me to be present to join you all today. Everyone in this room already knows the challenges. You see this on a daily basis back home in your states and in your communities. But this is actually a national problem at the beginning where we need to provide help back down to the local communities. So we need to work together to try to address this. On the opioid issue, nationally, the provisional data from CDC was just released, and it indicates that the death rate for total overdoses is now approximately 198 people per day to drug overdoses, most of those involving opioids. Earlier today, the Office of National Drug Control Policy released the 2017 Mexican poppy cultivation and production numbers. Poppy cultivation is up 38% to 44,000 hectares, bringing potential heroin production up to 111 metric tons, which is a rise of 37%. But beyond heroin, synthetic opioids like fentanyl and carfentanil are even more potent and causing more and more deaths every year. This opioid crisis is front and center at the White House. It's front and center for so many of you back home in your states. But the president has made this, like you all, one of his top priorities. The administration has sent nearly $1 billion out to the states so that you can target the response based on the individual needs. But the president has also signed $4 billion for opioid issues into law earlier in March for law enforcement, public education, drug courts, treatment research, recovery services, prevention, and importantly, safer prescribing. HHS has approved 13 state Medicaid waivers to help people in your states with substance use disorder, and Secretary Azar at HHS, as well as we want every state that has not applied for this waiver to send in your application. The President's opioid initiative seeks to reduce demand through public education and ending the overprescription, ensure that people can access evidence-based addiction treatment, as well as the important recovery programs. But we also need to cut off the supply of illicit drugs and bring drug traffickers to justice. On interdiction efforts, one of the things that I wanted to mention, in addition to some of the great things USPIS is doing, is FBI's J-Code, which was formed last summer to fight online drug trafficking. And last week, Attorney General Sessions announced the formation of Operation Synthetic Opioid Surge, SOS, to reduce the supply of deadly synthetic opioids and identify distribution networks. But as you all know all too well, this threat is not just opioids. Of the 198 overdose deaths per year that I mentioned that just came out, 1/3 did not involve opioids at all. Instead, they involved cocaine, meth, and other drugs. But just like heroin in Mexico, cocaine production in Colombia is now at record levels, and most of it is headed to the United States. 93% of the cocaine that is tested in the United States originates from Colombia. And in 2016, there were more than 10,000 deaths involving cocaine, the highest on record. Colombian cultivation went up 11% last year, but meth is also seeing a resurgence, especially in the West and in the Southwest here. There were more than 7,500 deaths in 2016 involving psychostimulants, which is another record high. Drugs are being smuggled across the border, purchased on the dark web, and shipped through the mail. The threat is constantly evolving. We have to be ready for these new vectors as they come into the country. At ONDCP, we coordinate federal drug control efforts. We work closely with your states to reduce drug trafficking and prevent drug use through our HIDAs, through our drug-free communities, which are represented in all 50 states. Now, with the latest HIDA being announced by my office 6 weeks ago, in Alaska, bringing that total to all 50 states. But we also provide grants to your states for drug courts, which, as you know, can turn participants' lives around and save taxpayers thousands of dollars for each participant. I encourage you to make sure your drug court system is robust, but that it is also partnering with evidence-based treatment programs that offer medication-assisted treatment for those who need it, facing an opioid addiction, and for expanding eligibility. But what is critical is partnership. As with any major issue, you governors are playing the most critical role. I want to thank the National Governors Association for continuing this focus. Many of you here were back in Washington in February for the NGA winter meeting, and I met with several of you all then at the White House event. But no matter whether it's opioids, cocaine, meth, or another drug, we do need this whole of government, federal, state, and local, for the local police departments, health communities, back up to the federal government to play a role. Together we can save lives, we can strengthen our communities, and we can help safeguard our country. I'm looking forward to hearing from you about what's working in your states and what we can do to partner with you moving forward. Thank you.
Good afternoon. I appreciate the opportunity to speak with you today regarding our efforts to combat opioids in the mail. As Executive Director of International Operations for the United States Postal Service, I oversee the Postal Service International Service Centers, or ISCs. Joining me today from the U.S. Postal Inspection Service is Inspector in Charge James Buthorn. INC Buthorn has nearly 30 years of law enforcement experience and currently leads the Contraband Interdiction and Investment Group for the Inspection Service. We are actively working to provide and collect the receipt of Advanced Electronic Data, or AED. Together with our federal agency partners, we are committed to working with foreign postal operators to increase AED for packages coming into the United States in order to improve the targeting of illicit drugs and other contraband. We collect AED for more than 90% of outbound international mail. In the past 3 years, we have increased receipt of AED on inbound shipments from virtually nothing to 40% as of June 2018. A substantial portion of those originate in China. The amount of AED from China is expected to significantly grow by the end of this year, and we expect overall AED percentage to increase to over 70% by year's end. Since January 2017, the number of countries sending AED to the Postal Service has grown from 8 to 38 and includes China and other countries of interest. We have prioritized obtaining AED from the largest volume foreign operators, which collectively account for over 90% of all inbound international volume. We now require AED on packages where rates are established under bilateral agreements and currently have such agreements in place with multiple postal operators. Moreover, 62 foreign posts have entered into voluntary data sharing agreements to facilitate the exchange of AED. In September 2017, the Postal Service and CBP completed a memorandum of understanding to solidify our interagency partnership. Additionally, a program initiated in the JFK ISC to use inbound international AED to facilitate more advanced targeting by CBP has been expanded to all 5 ISCs across the country. Over the last year, the Postal Service has provided hundreds of thousands of AED records to CBP daily and expanded the number of countries and types of packages available for targeting. We have also implemented and automated processes to identify targeted pieces requested by CBP. Furthermore, we have improved our presentation rate to over 90%, and this summer we will implement additional measures to further enhance our ability to capture packages that are targeted. To further improve the federal government's coordination and oversight over inbound international items, the Postal Service, CBP, and FDA formed an interagency work group. This group is working on efforts to build capacity to exchange AED, develop detection technology, continue information sharing, provide technical assistance for legislation, and improve physical and IT infrastructures. We also continue to work in close collaboration with our law enforcement branch, the Inspection Service, which has seen significant improvements in its ability to seize opioids. From fiscal year 2016 through fiscal year 2017, the Inspection Service achieved a 375% increase in international parcel seizures and an 880% increase in domestic parcel seizures related to opioids. Moreover, the Inspection Service has a full-time liaison at ONCDP, who is responsible for collaborating on drug control policy and law enforcement strategies related to mail. The Postal Service agrees with the goal of increasing AED to aid CBP in refining targeting of illicit drugs. However, unlike private express carriers like UPS and FedEx, the Postal Service must accept and deliver mail from nearly every country in the world. As we do not control the induction of foreign mail destined for the United States, we cannot control the collection of AED abroad. In conclusion, we share the concerns about illegal drugs and contraband entering the country through mail and commercial carriers. The Postal Service is committed to taking all practical measures to ensure our nation's mail security and provide the best, most efficient service possible. I thank you for this opportunity to speak, and I look forward to our panel discussion.
So there are some popular narratives to explain the opioid crisis and the drug problems that we're having today that are incorrect. And it's easy to understand why people are drawing some of the wrong conclusions. We do know that for the past 20 years, every year we've set a new record for death from drug overdose. And then the next year we break that record. And we know that for the first 15 years of the opioid addiction epidemic, which began in the late 90s, it was prescription opioids that drove the increase. And then about 5 years ago, prescription opioid deaths stopped going up so rapidly, and we started to see deaths involving heroin and fentanyl and cocaine and methamphetamine begin rising. And one of the explanations that people are drawing from these trends is that the drug users, there was a crackdown on the pills, so the drug users switched over to these other drugs. And I can understand a governor looking at this and thinking, gee, it's like a game of whack-a-mole. And you try and do one thing about one drug problem and it makes another drug problem worse. I like a conclusion that people could draw from this, which is that we need to be able to treat all of the different drugs that people are addicted to, not just opioids, but really people are drawing the wrong conclusions by looking at the overdose deaths. It's not that there's been a sudden increase in heroin use or methamphetamine use or crack cocaine use in the past 5 years. That actually hasn't happened. The switching from prescription opioids to heroin among young adults in the United States began happening in the early 2000s. Young people who were becoming addicted to prescription opioids, once they got addicted, they would have a hard time continuing to get pills from doctors. Doctors don't like to give healthy-looking young people a large quantity of pills on a monthly basis, so the young person would wind up on the street. The pills are expensive on the street. If that young person was in a region of the country where heroin was available, they'd switch. And what we've seen happen steadily, not in the past few years, but steadily from the beginning of the prescription opioid crisis, we've seen heroin move into more regions of the country where it wasn't previously available to meet the demand for it by this growing number of young people who became addicted. What starts to happen in around 2011, 2012, and more recently, isn't a sudden switching over to illicit opioids. It's been a sudden increase in the deaths with the emergence of fentanyl. Not a larger number of people suddenly using cocaine, methamphetamine, or heroin, but a much more dangerous drug supply because of fentanyl. And one of the reasons people are making this mistake of drawing the wrong conclusions is they're thinking about the opioid crisis as an overdose crisis. Overdose deaths are really just one aspect of the problem. We're also experiencing a soaring increase of infants born opioid dependent, children winding up in the foster care system, outbreaks of injection-related infectious diseases, impact on the workforce. The driver behind all of these health and social problems has been a very sharp increase in the number of Americans suffering from the disease of opioid addiction. That's really what's been going on. Now, it's important to understand that we don't have this single group of drug users or people who are addicted that switch from one drug to another. We actually have three groups of Americans who are opioid addicted. The first group gets quite a bit of attention. They are predominantly white, in their 20s, 30s, early 40s. This is the group that's been switching to heroin after becoming addicted to prescription opioids. A second group of people who've become addicted over the past 20 years are people who are middle-aged and older who are becoming addicted to prescription opioids, often through medical use, That middle age group is not switching, and that middle age group has been overdosing on the pills. And then we have a third group of Americans who are opioid addicted, and these are really survivors of the heroin epidemic of the 1970s. This is a group that's more likely to be Black or Latino. They're in their 50s and older. And it's a group where deaths are also rising right now because it's a heroin-using group. So because of fentanyl entering into the heroin supply in this group of survivors from the heroin epidemic of the 1970s, the deaths are also soaring. So among these two groups, though, that became addicted post-1995, which are predominantly white, the reason that they became addicted, the reason we have this new opioid addiction epidemic has been really made perfectly clear by the CDC. The CDC has shown that as prescriptions began to soar starting in the 1990s, overdose deaths and addiction went up right along with the increase in prescribing. And although prescriptions have come down a little bit in the past few years, we are still massively overprescribing in the United States. We prescribe far more than any place else on earth, and we're prescribing far more than we were in the United States prior to 1995. So what we're dealing with is an epidemic of opioid addiction caused by overexposing the United States population to this highly addictive drug, prescription opioids. Now, the reason the medical community began to prescribe so aggressively is because we were responding to a brilliant, multifaceted marketing campaign. Now, had doctors just heard from drug reps for Purdue Pharma that patients don't get addicted, we would have been less gullible. But we were hearing from pain specialists eminent in the field of pain medicine that we should be prescribing more, that patients are suffering because we're too stingy with these medications. We were hearing it from our professional societies, our hospitals, even state medical boards were encouraging the medical community to prescribe more. And as we responded to this epidemic and the prescribing took off, it led to the epidemic that we're dealing with today. Now, what do we do about our opioid addiction epidemic? And I do think it's important to think about other drugs. We should be concerned about methamphetamine, but methamphetamine use is actually declining in some parts of the United States. It's declining on the West Coast. It's increased a bit in the Midwest. Cocaine use is actually decreasing. There are certainly other drug problems that we have to be equipped to treat and that states need a licensed drug treatment system to address. But I really don't want you to take your eyes off the prize, which is that we've got to tackle the opioid addiction epidemic. This is the most urgent public health problem facing the country. To bring this crisis under control, the strategies are pretty clear. We have to respond to this disease epidemic the way we would respond to any disease epidemic. What would we do about a disease outbreak? Well, the first thing we would do would be to contain it, to prevent more people from getting the disease. And we'd see that people who are suffering from this disease have access to life-saving treatment so they don't die from the disease. That really is the overall strategy for responding to the opioid addiction epidemic. And we know that the vast majority of people who've become opioid addicted post-1995 became addicted taking prescription opioids. There are many strategies for preventing opioid addiction, but the most important strategy is we need much more cautious prescribing so that we don't directly addict patients and so that we don't indirectly cause addiction by stocking medicine chests with a highly addictive drug. But for the millions who are now suffering from this condition, they need access to effective treatment. Somebody who's opioid addicted, when they wake up in the morning, they're already going to be feeling sick. Someone who's a heroin user will probably try and have some heroin by the bedside because they know when they wake up, if they don't use right away, they're going to be feeling very ill. If that individual has a few bucks in their pocket and they know where they can go buy a bag of heroin and they know they're going to be feeling sick soon, that's what they're going to do. If we really want to see deaths start to come down, that opioid-addicted individual needs to be able to access effective outpatient addiction treatment more easily than they can access heroin, fentanyl, or prescription opioids. And to get there, we really need to adapt the state licensed drug and alcohol treatment system. The systems that you have in your states today are actually fairly well equipped for handling cocaine addiction and methamphetamine addiction, because the approach to treating those conditions are psychosocial interventions and counseling. But the state licensed drug and alcohol treatment programs in general don't have many medical staff and are not really equipped for treating opioid addiction with medication. If we want to see deaths begin to come down, we have to see patients having better access, particularly to buprenorphine. When I say that if there was better access to buprenorphine, also called Suboxone, that we could see deaths start to come down in the United States, I'm not just speculating. We saw it happen in France. In the mid-90s, buprenorphine was released in France without the restrictions that we have on it in the United States. Within 6 years, there was a 79% drop in deaths from heroin overdose because doctors began to widely prescribe buprenorphine. If we had better access, particularly for that medication, I think we could turn the corner. But very few state licensed drug and alcohol treatment programs in the United States are offering that treatment. Patients who are accessing it often have to access it from a solo practice doctor who doesn't take their insurance. Their commercial insurance or their Medicaid may be covering the prescription, but they're paying out of their own pocket for that doctor's visit. And so, again, if you want people to access treatment instead of continue to use, it's got to cost less to access a physician who can prescribe medication for your addiction than it is to continue using. So, in summary, the United States is in the midst of the worst drug addiction epidemic in its history. It is an opioid addiction epidemic. Yes, we have other drug problems that get better or worse, but the most serious problem is, in fact, opioids. To bring this problem under control, we have to prevent more Americans from becoming opioid addicted, and we have to see that the millions who are suffering from this condition can more easily access effective treatment.
Thanks. We're running a little bit behind schedule, so I'll try and keep the panel discussion here a little short. But I did have a question to begin for Mr. Carroll, and that had to do with the OIG report fairly recently took a look at how ONDCP has been doing on some of its strategic goals. One area that was where progress had been made was there was a decrease in consumption among some groups, especially younger people. And I was wondering if you could tell us a little bit about the relatively recent ad campaign that ONDCP has launched. And it's the Know the Truth, Spread the Truth campaign. It was fairly controversial. Some of the messages are quite stark. And I'm wondering what you've seen as a result of those ads going out.
Thank you for asking and bringing attention to the 4 new PSAs that are out. And they are designed on the prevention side, and it really is know the truth. I'm traveling the country just like so many of us, and talking to so many parents who didn't even know that their child had an addiction. And so the idea behind these, we tested 150 different commercials, different PSAs, to get down to these 4 that were determined to be the most effective by the 2 media companies involved to help support us in this effort, to make sure the parents as well as the kids who are the most at risk really understand what they're facing. They are stark, but this is just the beginning of more commercials to come that will talk about every aspect of this epidemic. The doctor is right. I mean, this really is an epidemic that we're facing. It is an opioid epidemic in the sense that the opioids, especially the synthetics, are causing the lethality, but it's the initial use of the opioid that starts the addiction. One thing that I did want to mention, just to echo exactly what the doctor is saying, the CDC data that was just released, it is provisional, it's not final numbers yet, but it shows that from 2015 to 2016, the number of heroin deaths is essentially flat. All of the deaths, or the vast majority of the deaths, are coming from fentanyl. And so, and again, I think that speaks to the availability of fentanyl in this country. It is cheap, it is incredibly potent, incredibly lethal, And so it's through the good work of partnerships that we can draw attention to this, because the heroin deaths are flat. Cocaine is up, meth is up in terms of deaths, but it really is the fentanyl that's hitting us in such a dramatic way.
Thanks. I mean, that leads us right to the next question for Mr. Rains and Mr. Buthorn. Could you tell us a little bit about how this data that you're trying to get from foreign shippers is used? Could you give us some examples of how you've been able to take that and then make a difference?
Sure. So with this data, we have very strategic partnerships with multiple agencies. We have people embedded full-time at the Drug Enforcement Administration's Special Operations Division. This is one of the gold standards of data sharing in the world. The National Targeting Center, our partnership with the Customs and Border Protection, has never been stronger. We provide data, the analytical data, along with seizure data and other points of reference that go into the big machines that these guys have ability to, the big data. We take that data then and then identify suspicious tendencies of packages, of targeted packages. Those packages are then electronically held out and inspected by Customs and Border Protection, and investigations are followed up with our partners again from Drug Enforcement Administration, Homeland Security Investigations, Federal Bureau of Investigations, and the Postal Inspection Service.
Great, thanks.
Yes, sir.
Dr. Kolodny, I have a question for you, and that is, what is holding back medication-assisted therapy or treatment in this country? You mentioned the experience of France in your close. I mean, I know it's multifaceted, but if there were a few things that you could change, what would they be when it comes to buprenorphine, but maybe the other examples, the other options as well?
Yeah, so I think buprenorphine is where we have one of the greatest barriers, and I think there are many reasons, there are many barriers to patients accessing this treatment. There are ideological barriers, for example, where even some folks in the treatment community are under the wrong impression that if you're treating opioid addiction with buprenorphine or methadone maintenance, that you're not really, it's not really treatment, you're just substituting one drug for another. So there's a bias, but I think the single biggest barrier to patients accessing this treatment is that there's an 8-hour training requirement before we allow a doctor to prescribe it. And I think that's the reason only 4% of doctors in the United States are even eligible to prescribe buprenorphine. If you require an 8-hour course and an application process, if you put that between a doctor and a medicine, you're going to see far fewer prescriptions for that medication. So if I had to name just one huge barrier, it's that 8-hour training requirement. Some of the other barriers have been eased a bit, like patient caps. When buprenorphine was first released, there was a cap on the number of patients that could be treated. A doctor was limited to just treating 30 patients, and then that got lifted, and it's been lifted again. I should point out that for a drug like oxycodone or hydrocodone, which are an OxyContin and Vicodin, there are no caps. The doctor could prescribe as much as they want to as many patients as they want. So there are many barriers, but I think the single biggest is the 8-hour training requirement.
Thank you. I think we'll turn now to the next part of the program.
So we open it up for opportunity for governors to.
Actually, we're going to have the First Lady from North Dakota speak to us.
Governors. I want to thank again our panelists for their insights into these issues, and now it's my pleasure to welcome North Dakota's First Lady, Catherine Helgas Burgum. As First Lady, her top priority is supporting initiatives to eliminate the stigma of chronic disease of addiction. We welcome the First Lady, and we greatly appreciate her willingness to speak to us today about her own personal experiences and on her leadership in combating this crisis.
Thank you, Governor Dayton, for your kind introduction. It is an honor to stand before all of you today. I would like to extend my deepest gratitude to NGA for inviting me to share today, and for the proactive work they continue to do around the issues of the opioid crisis and addiction. And thank you to everyone in this room, governors, fellow first spouses, and the hardworking staff and team members who get up every day ready to transform the lives of citizens across our country. There are two things I never thought I would ever do. One is be First Lady of anything, and two, have the opportunity to share my story to a room full of the most impassioned leaders committed to leadership and change in our communities. But by some crazy set of circumstances, or maybe by divine intervention, I am both First Lady and am standing in front of you full of gratitude for the opportunity to be here today. The chronic disease of addiction, including the opioid crisis, are some of the biggest challenges facing our nation. I don't pretend to be an expert on the disease of addiction, but I do have lived experience. I've been in recovery from alcohol addiction for over 16 years. Thank you. I spent 15 of those years in silence, keeping my recovery in the closet like a shameful secret. Sadly, only 1 in 10 people who need treatment for addiction actually seek treatment. And I know that because I was one of those statistics. I knew for years that I needed help, but I didn't seek it because I was ashamed. For people with the disease of addiction, 3 words have deprived them of medical treatment: empathy and compassion, for decades, or more like centuries. And those 3 words are shame, stigma, and discrimination. My journey with addiction started when I was in high school in North Dakota when I first started drinking. I knew as a teenager I didn't drink like others. I had my first blackout when I was in high school. I struggled with alcohol-related issues and episodes over the next 20 years. I chose to live and work in cultures with excessive drinking. I had no desire to attend events without alcohol, and I couldn't imagine my life without alcohol. While constantly struggling with my addiction, my career progressed, and I had forward movement in my life, but I could never reach my full potential with my addiction holding me back. There came a time when I knew I needed to stop drinking, but addiction's a powerful disease, and it kept me drinking for many years. I could achieve any goal I set for myself, but I could not stop drinking, even though I experienced many baffling, demoralizing, and defeating drunk episodes. I'd stop drinking for 3 months, and then I'd start again. I'd stop for a year, and then I'd start drinking again. And this cycle continued over a period of 8 years. I'm so grateful that my higher power kept asking me to pull on my boots and try again. I finally became willing to do whatever it would take to stay sober. And when I became completely willing, that's when the miracle happened for me. And I started staying sober. I found a program that's built on a foundation of gratitude, of helping others, and a higher power, and it has saved my life. I will forever be grateful to the program and its people for embracing me and helping me find recovery. My openness about my recovery has started what I hope will be a lifetime of advocacy, speaking out for those who've been misrepresented and misunderstood, and creating opportunities for people, families, and communities devastated by this disease. As First Lady, it's my ultimate mission to end the stigma and shame of the chronic disease of addiction. Stigma, which is defined as the mark of disgrace, is a persistent barrier to effectively confronting addiction and finding recovery. With addiction, stigma puts up walls instead of building bridges. It is socially constructed, based in fear, and usually accompanied by a lack of inaccurate information. I met the parents of a teenage boy who died of an opioid overdose in his car in a high school parking lot. They were devastated by their son's needless death. However, there was no outpouring of community support like there would be for a teenager who died of cancer or of a car accident. Shame and stigma keep people away. I believe addiction needs to be embraced like any other chronic, progressively fatal illness or disease before real changes can be made in our communities and before the shame and stigma can be eliminated. Addiction is not a choice. It's not a character flaw, and it does not discriminate. The stigma of addiction started way back in the 1930s when scientists began studying addictive behavior because people addicted to drugs and alcohol were thought to be morally flawed. And those views shaped society's responses to addiction, treating it as a moral failing rather than a health problem, which led to an emphasis on punishment rather than prevention and treatment. Alcohol addiction was declared a disease by the American Medical Association way back in 1954. Welcome to 2018, where addiction is still viewed by many as a lack of willpower and a character flaw, and is amazingly still approached with punishment rather than treatment in many communities. The punishment approach brings with it a powerful shame and stigma that influences our laws, our services, research, healthcare, and support for people with the disease of addiction. Now more than ever, we must be driven by data and facts and recognize the science behind the chronic brain disease of addiction. Scientists, physicians, and even the Surgeon General agree that addiction is a disease. When people have the chronic brain disease of addiction, their brain gets hijacked in a biological way, manipulating dopamine levels to tell the person the highest priority in their life is the disease of addiction, and the only choices are drugs and alcohol. It's hard for people to accept the concept that addiction is a disease. I know how hard it is because I didn't believe it myself. I thought I could make the right choices. I thought I could do the right thing. But after relapsing for 8 years and literally thinking that I must be insane, I now understand that no one would choose to live that life. No one chooses drug overdoses or to lose everything in their lives because of meth or to die from years of addiction to alcohol. With compassion, we need true understanding. And sometimes that understanding comes from having the humility and courage to unlearn the things that we've held as truths for our entire lives. A universal acceptance of addiction as a disease across our nation will save lives and provide futures for our next generation of leaders and innovators. It may come as a surprise to you, but there's actually a simple solution to eliminating the stigma of addiction. A solution where everyone across the nation can participate. The simple solution is talk. Those in recovery sharing their stories, caregivers talking about those that they help struggling with addiction, those in public service talking about addiction and recovery, and corporations creating safe environments for people to talk about addiction and recovery at work. Talk will eliminate the elephant in the room and normalize the conversation around addiction. If we do this, the stigma will be eliminated. More people will seek treatment and find recovery. And everyone who is talking about addiction will be saving lives. This is a grassroots movement that costs nothing, doesn't need any legislation, and could easily be the one thing that crosses all political party lines to unify and truly make a difference for our nation. The opioid crisis has brought addiction to the forefront. While the focus revolves around opioids, addiction is a constant no matter the substance. This evolving crisis needs to be met with a holistic, adaptive response, especially in our healthcare systems, that focuses on the disease of addiction rather than creating systems and processes for one specific drug, opioids. Treatment can work and recovery is possible. And there continues to be innovation in treatment and recovery. One of the leaders in the field of addiction is the Hazelden Betty Ford Foundation. They've created an innovative program called Core 12, which combines multiple approaches, including medication-assisted treatment, therapy, 12-step programs, and peer support. In North Dakota, we're focusing on several innovative initiatives. We're working hard to eliminate the shame and stigma of addiction in our state. We will be using evidence-based methods to create a system to measure our progress on eliminating stigma. In collaboration with our behavioral health team and the Addiction Policy Forum, we are conducting a survey to establish a baseline measurement for stigma that we can measure against in the future. Data will show if we're moving the needle. Data helps drive funding. Data can change minds and create systems to ultimately save lives. 80% of those incarcerated in our state have an addiction. They need treatment and not incarceration. During the last 30 years, it was thought that more punishment would mean less addiction. Those with the disease of addiction who are convicted of nonviolent, possession-related crimes carry the extra burden and stigma of being a felon when they are released from prison. And they often receive no treatment for their disease while incarcerated. After doing their time and paying for their crimes, felons can't find jobs, and they can't find places to live. The felony discrimination towards the disease of addiction perpetuates the cycle of addiction. Through an innovative program called Free Through Recovery, we are giving those dealing with substance abuse who become entangled in the legal system the opportunity to recover successfully in their communities with care coordinators, with support from care coordinators and peer support specialists. And reimbursement for the Free Through Recovery program is outcome-based, with opportunities for incentive funding for meeting performance benchmarks. This reimbursement model is innovative and unprecedented. And this model pays for wellness and recovery. And the program is working. Goals are being achieved, incentives are being paid, and active revocation and absconder rates are decreasing in our state. As we build recovery support for the citizens of our state, this is a model that we would like to roll out to all of our citizens, not just those in the criminal justice system. So to close, I'm so grateful and honored to NGA for inviting me to be with you today. I encourage all of you participating in policy development around the disease of addiction at both the federal and state levels to include people in recovery, to help shape the policy that can truly make a difference. Bring those with lived experience to the table to show what recovery looks like and help provide the hope for the future. Now is the time to put aside stereotypes and put aside intolerance. Now is the time to come together to help those suffering from the disease of addiction. Now is the time for every one of us to take action in our own lives, in our work, and in our communities. There's no shame in addiction, and there's so much hope and possibility in recovery. I am like more than 23 million other people across our great nation who has the disease of addiction. And I am a face and voice of recovery. Thank you.
Thank you very much for those moving remarks. We'll now move on to the discussion portion of our panel, and I thought we might start off by talking with the governors a little bit about how the drug use, how the how the scene of drug use and abuse in your states might be changing. We heard that in some parts of the country, meth is on the rise, cocaine is also being produced at record levels, and I'm wondering, we've had a focus on opioids, but is there more about the picture of what's happening in your states that you'd like to talk with us about?
Be happy to address that. I mean, Kentucky obviously is often thought of as a part of the epicenter of the epidemic, and it's true enough in many respects, that whole region of the country, and we're smack dab in the middle of it. I will say this, there was a question, it was a good one, about what are some of the things that would prevent better progress on this front, and I think the one you mentioned is spot on, but there's other ones, simple things that we've done, IMD exclusions, that preclude us from having more than 16 beds and things of this sort. Making certain things like an naloxone a legend drug and not readily available. Little simple things that cost nothing to change, that are government regulations, that frankly are counterproductive in some respects. I've recently written a letter to Director Collins at the NIH. A number of other governors, including some around this table, signed on to that. And what we were asking is that we could get some real guidance comparing various medically assisted treatments, or MATs as they're often called, one to the next, whether it's a buprenorphine or whether it's naltrexone or methadone, whatever the case might be. That there are many different methodologies that could be used, and that we as governors, we're not doctors, we're not experts in most instances, and so to that end, how can we compare one of these to the next? How can we be better informed about what technologies and medicines and treatment programs are there? One thing I want to touch on real quickly, and it's something we've spoken about earlier on a number of occasions. The CDC has made very clear that the path to addiction is 5 days and beyond. For those that are more inclined to become addicted to opioids, that hockey stick of addiction begins after 5 days of continuous use. And yet the average in America is still a 10-day prescription, which is remarkable to me. Kentucky, it's now 3 days. It's by far the lowest in the nation. And frankly, why do we even have anything more than 5 days if we know that's the point at which people fall off the cliff that are likely to do so? So simple things like that. We've also, through an 1115 waiver, people tend to focus on it for the many facets of it that they may not like. But one of the things that we've asked for in Kentucky is to be able to use Medicaid dollars for treatment in innovative ways that have not historically been the case, not the least of which is this exclusion on the number of beds. There's a lot of different ways in which we can be smarter about this, but it is an epidemic, and the last thing I'll say is this, unless to the points that have just been made on several fronts and by several of the speakers, until we are as intentional about this, as passionate about this, as focused about this as we were on, say, the AIDS epidemic of a generation ago. At the height of the AIDS epidemic, 54,000 people died. It was horrific. It had the fascination, and for good reason, and of this entire nation and of the world. And you saw people across all segments of the population coming together trying to address this, the medical community, the popular culture community, entertainment community, whatever the case might be. The numbers that were released most recently, 60,000 people last year. Preliminary numbers would have us, I believe, at about 72,000 last year that overdosed in America. We're still not taking this seriously enough. And the final thing I'll say is this, on so many fronts, there's a lot of things that might be able to be done. But I think we need to be more intentional too, both as governors, things that we can do in the medical schools in our communities through our public institutions, but from the federal level as well. Why is there no requirement for licensing purposes for doctors to have better education on the actual prescription process and the effect of this particular types of drugs, these opioids, the pharmacodynamic effect of which is very different than a lot of other pain drugs that have been prescribed through the years? And why, as part of rotations, for example, are doctors not required to do a rotation in a recovery center? I think that kind of experiential learning costs nothing, but it truly would have a tremendous impact and would help to start to change the fact that in Kentucky, for example, last year, even with some of the implementations that have now just begun to take effect, just prior to that, 359 million doses of opioids to 4.5 million people. 79 pills for every single man, woman, and child in our state. And sadly, we don't lead the nation on that front, although we're near the top. These are the kind of things that have to happen. It's a result of us having conversation, but it is a collective effort, and there's a whole lot of things that can be done that cost nothing to get this done.
Thank you. Governor Dayton?
Director Raines, I understand that most of the fentanyl comes into this country through the Postal Service or through private mail carriers. What are your strategies to increase your interdiction and be more effective at preventing that?
Well, I'll take it from an operations perspective. INC Boothorn is our inspection service liaison and would probably be able to help better understand from a law enforcement perspective. So we are working with CBP to build better technology to identify the pieces that they think need further inspection. So that's our role in the process from the Postal Service perspective, is that they identify pieces that are likelihood high-risk pieces, and we interdict those pieces in the mail stream and provide them to CBP for further inspection. Postal employees have no authority to open or inspect any mail pieces, and even our inspection service personnel have limited authority with probable cause, and they have to get a search warrant. So I'll turn it over to Mr. Boothorn.
Thank you for the question, sir. So the inspection service has the duty to deal with this problem from the international point of origin to the streets. So what we've done is we've put together a group of subject matter experts and strategically placed them, as I mentioned earlier, at places such as the DEA, SOD. But it's also forming strategic partnerships with groups like ONDCP and the HIDA groups, where we exchange data and share data readily. I challenge my team every day to break down silos, to make sure that we're not working in silos, and I love that I'm hearing it, the whole government approach. I know we're down the right path because you hear the term a whole government approach, and we're all in on that. The data sharing between the international community has been great for us, and what that's doing is that's transcending down to the street level, to the officers and your local law enforcement partners that we work with every day. As we gain better intelligence through the analysis of the data that we have, we're able to strategically deploy our resources, one, to interdict, to reduce the amount of drugs that are hitting the street. You've heard the increase in success we have with the 800%, the 375% increase in our domestic and international seizures. It's not time to spike the ball. We take this very seriously. We're working very hard. But once that intelligence transcends down to local law enforcement, we don't just end there. We take that data that we glean from the streets and bring it back up into our modeling so that we can interdict better, have better modeling and better tools that we use. The big piece, the big component, I'll give you an example of how this works. If a package is intercepted, again, our team working with our partners get all the research intelligence we can to get that intelligence to the hands of the investigators in the street. Once that data gets down to that street level, they do their investigation, they make their arrests, whether it be referring people to drug courts, right? We're not going to arrest our way out of this problem. We recognize that. But it's those partnerships to, once we make those arrests or make those enforcement operations, to take the data to bring it back up to work with our international partners. And one strategic partner that we have in this is HIDA. They have a project called OD Maps, Overdose Maps, and I believe Governor Edwards referenced before the tracking of overdose deaths. OD Maps, in simple terms, is geolocating the opioid overdoses. So if an officer, a first responder in the street, responds to somebody that is overdosed, it's a simple app on their phone where they click and that data is collected. Once that data is collected, we use it for three things. One, we try to use predictive analytics to say, hey, if there was a parcel in that, an express consignment parcel in that scene, hey, there might be other parcels connected to it. So let's get that information as soon as we can, and we get it instantly from OD Maps. There's a a place where you can enter that parcel information. As soon as that parcel information is added, it goes directly to our team that has access to all the data places we spoke of, such as DEA's SOD and the National Targeting Center. So right away, our first aspect is, can we save lives by finding additional parcels that are in whether it be the mail stream or other consignment couriers in that stream. Take those out of the mail. Next, we try to focus our interdiction efforts by sending our resources to those areas, or focusing our interdiction efforts to take those drugs out of the mail. And finally, we're having a lot of success with assisting local law enforcement with the follow-up investigation. If the overdose resulted in a death, and I can off the top of my head, as an example, there was recently in Arkansas, off-duty police officer who overdosed. We immediately jumped into that investigation and were able to find that he was purchasing his substance through the dark web. I'm not a person that likes to brag, but we're at the forefront of the dark web investigation world, especially with our partnerships at J-Code. We were able to identify a gang out of Washington, D.C. The Washington Division did an outstanding investigation, again, with our partners, and took that gang out of commission. They were responsible for mailing an estimated 500 plus packages. So we were able to take them away. So that is an example of how, from the big data, we can work down to the street to help your local communities across the country. I'm sorry for the long-winded answer. But.
I had a question for the governors, which stems from Governor Edwards' remarks, and that is, what is the role of Medicaid in the opioid epidemic and the response in the states, and do you have what you need in order to put it to best use?
Well, I'll give it a shot. You know, I'm not going to say we have what we need, but we believe that it is certainly helpful that we have behavioral health integrated into our Medicaid program, so that addictive disorders and mental health are both areas where beneficiaries can receive help. We also believe that it's essential that we work with CMS to gain more flexibility. You know, for example, archaic rules, and I know that Governor Bevin touched on this, about the number of beds that you can have in a facility when you may need more beds, or how many days an individual can stay in a facility even though they need to be there more. And we're finding CMS to be very receptive on that, especially when you can demonstrate that at the end of the day there will be a lower total cost to the taxpayer by granting the additional flexibility. So we find that has been very, very helpful. But the Medicaid rulemaking that we can do at the state level to impact the initial prescription of opioids for acute pain was critically important for us. I was very pleasantly surprised to find out that the number of prescriptions and the number of pills prescribed in our state actually decreased after we expanded Medicaid and made prescription drug coverage available to 460,000 adults. So I know that I'm not going to say we're where we need to be, because we got a lot of work to do. One of the questions I've got is, what is the right number of days of opioid prescription for that initial acute pain? Is it 3 days, 5 days, 7 days? Is there a national standard? Because I know the states are all over the place. I was really proud of our 7 days till Matt started talking about his 3, and maybe we need to do better than that.
Yeah, Dr. Kolodny, do you have any thoughts on that?
Sure. And I appreciate Governor Bevin bringing up that issue, and you're asking me about it. Overprescribing of opioids for acute pain is a huge problem. That's how many people wind up long-term opioid users. There are studies that show that if you take an opioid every day for 10 days, 1 in 5 people are still on an opioid a year later. And if you take an opioid every day for 30 days, about 40% of patients are still on an opioid 1 year later. The CDC's recommendation, initially their recommendation was 3 days. There was a little bit of pushback on that, and they changed the recommendation to read something like 3 days are usually enough. more than 7 days is rarely needed. And states have been passing laws limiting first-time prescriptions. Some states have gone with 7 days, some have gone with 5 days. One of the problems, though, is that there are always going to be some exceptions. So for the vast majority of patients with post-operative pain, 3 days is usually enough, and there are many patients with severe pain that you can even give them alternatives to opioids, like non-steroidal anti-inflammatory drugs. But there are also going to be examples of patients that can't take an NSAID and who may have had, for example, open heart surgery, where they literally crack open your chest. You may need more in some cases than 7 days. So it's hard to pass a law, and there's pushback from the state medical societies who say to governors, you guys didn't go to medical school, you're going to tell us how to practice medicine. And I think a good response from the governors would be, if you guys knew what you were doing, we wouldn't be in this mess. I think that a better way than passing a limit on a duration of use, there are better ways to get at this problem, to create a new default of 3 days or less. But by the way, if you pass a law of 7 days, the average prescription is written take 1 or 2 pills every 4 to 6 hours. If you write 7 days worth like that, there can be more than 70 pills in the prescription. So I think the real problem is the quantity. So a smart way to get at this is to consider limits on quantity as opposed to duration. But the other things that you could do to create a new default is to make it a little harder for a doctor to prescribe more than 3 days. If, for example, you passed a law mandating that every time a doctor was going to prescribe more than 3 days, they had to have the patient sign a consent form that they've been warned about the risk of addiction, you'd have better informed patients who would know to maybe turn away the prescription. But putting in that extra hurdle, you'd probably see many doctors, you'd see a decrease in the casual prescribing. And I think for the patients who really need it, a patient with cancer pain, for example, the doctor would break out the form and do the extra work. Another way of getting at a new default is something that Governor Bevin mentioned, which would be a federal mandatory prescribing law. So if doctors across the country were required to take a course if they wanted to prescribe more than 3 days, many doctors would opt out. They'd say, I don't need to give more than 3 days, I'm not going to take the course. And they'd be limited to prescribing less than 3 days. And for the doctors and specialties where they need to prescribe more than 3 days, they would take the course. But I think you'd create a new default across the country.
Thank you. I think we have time for one more question, and I was hoping to ask about naloxone and what your states are doing in that regard. The Surgeon General earlier this year really urged much wider distribution of naloxone to family members and people in the community who are close to people who might be at risk. And I'm wondering how you've dealt with that issue. And I think Governor Martinez, would you like to talk to us about that?
Yes, we actually passed legislation that requires all of our local, state law enforcement officers to carry naloxone with them and have it available whenever they're out on a call. Also, naloxone can be given without a prescription and by a pharmacist. And got here, we have made it available via legislation so that it requires every law enforcement officer to have it on their belt. And so when they respond to an incident where someone has overdosed, they can immediately use the prescription. We've also removed prior authorization of Suboxone and expanded the number of methadone clinics as well as these clinics accepting Medicaid. I will say, though, although we've made it available, law enforcement can give naloxone to the same person several times. And so when you talk about treatment, I think it's very important to understand that the person has to want the treatment. And a lot of information is given to people. In New Mexico, they don't go to prison for the simple possession for personal use. Rare do they go to prison for the first time or even the second time. But as a condition of their probation is treatment, and they are provided the Medicaid documentations so that they can qualify and have access. But if they do go to prison, let's just say they robbed a store and had heroin, they can in New Mexico receive treatment. It's a 6 to 12-month program and inpatient, and they're at the prison, and then it's a condition of their parole when they get out. However, that is a voluntary process. If they don't want treatment, we can't make them go to treatment. And you have a captured audience in a prison if that they could take great advantage. Now, before they get released, we also help them fill out Medicaid applications so that there isn't a time gap of receiving the treatment once they're released from prison and are out in the street on parole, so that continue that outpatient treatment.
Thank you.
Scott, I would just add to that, in North Dakota, one of the initiatives of our courageous First Lady was an event called Recovery Reinvented, where we brought together people from across the state, law enforcement, education, healthcare providers, first responders, and as part of that conference, we showed a short film that was less than 10 minutes long. That was the training effectively on how to administer naloxone, and that people that wanted it stopped at a booth on the way when they left. About 350 people took naloxone when they left. 5 days after that conference, parents revived their adult son who was non-responsive in their own home in their bathroom with the naloxone they received at the conference. Within a few months after that, there was someone who was revived at a public library in North Dakota with naloxone. And I think, again, as part of the stigma, we have done very well as a nation to put AED devices everywhere as part of combating, heart disease and heart attacks, and really turning the corner on the fatalities related to heart disease. And I think that we have to, as Governor Martinez has done statewide and other governors, to really embrace naloxone, not just with first responders, but with the public awareness that anybody can save a life.
Mm-hmm. Yeah.
We're unfortunately going to have to conclude at this point, keep overall program schedule. I want to thank First Lady and our panelists for your participation, for your insight. I want to thank you, Mr. Hensley, and with that we stand adjourned.